Okay. Okay. Hello, everyone. Welcome to our second to last lecture in Intuitive Surgical's 2020 Global Da Vinci Thoracic Surgery Focused Webinar Series that we call the Global Chest Channel. This presentation will provide an overview of Dr. Cerfolio's journey as an MIS surgeon, and then a video review of some PA bleeding experiences in robotic procedures. The final webinar of 2020 will feature Dr. O again on December 12th in Asia, and the topic is future innovations with Da Vinci thoracic surgery. In this webinar, Dr. O will discuss future developments with the Da Vinci system, future Da Vinci instrumentation, imaging advancements, and further integration of information technology into our platforms. We are pleased to offer translation capability from English to Chinese and Japanese. To access the translation, please click the interpretation at the button at the bottom of your screen and then select your preferred language channel. There will be a 5 to 10 second delay as the audio adjusts between channels. Recordings and disclaimers. This webinar is being recorded and will be available for replay at a later date. The language in these disclaimers provides details to ensure legal and regulatory compliance for future airings. Please contact your local Intuitive representative for information about the re-airing date and time. We're honored to have Dr. Robert Cerfolio as the guest surgeon for this webinar. Dr. Cerfolio needs no introduction, but I'd like to express our gratitude for his acceptance to spend this time with us today. Questions are encouraged. You can submit your questions at any time during or after the presentation. And with my pleasure, I'll hand it over to Dr. Cerfolio.
David, thank you so much. God bless everybody. Good to see you. I know it's a crazy time with COVID and other things going on, but we look forward to have some fun today. And I want it to be interactive, so please feel free to give us your questions. So we're going to start off with a little PowerPoint presentation. And hopefully you can see my screen. We'll go to slideshow. How is that looking? Can everybody see me and see the slides?
Okay, yes, we're there. Good to go.
Great, thank you very much. So I think the title of the journey really, the title of the talk really is the key because of the word journey. You know, minimally invasive surgeon, a journey towards mastery. Each one of us listening to this lecture is really in a journey in life towards mastery. None of us achieve mastery. It's a destination that can't be achieved. And every master knows that. But the idea is to get better and better and better in all of your roles. And our roles are many. We wear hats as children. We all have parents, spouses. We may have siblings, grandfathers, grandmothers, mentors, teachers, learners, educators. These are all the many hats we wear. And we want to really become masters in them. Now, as a COO, I must have no conflict of interest, not even the perception of any. So I received no money for the lecture today, no honorarium. There's no glass of wine, no food, nothing since I've become Chief Operating Officer and Executive Vice President here at NYU Langone, which, by the way, boasts the highest quality outcomes in the world in our overall surgical care, not in just lung surgery, but everywhere. And I'm very proud of that. Now, in the past, it is true that I've received money from Intuitive and other companies for coaching. And I also have worked with other companies, not pertinent to today's lecture, but other companies that develop robotic systems and simulators. I think how we teach, who we teach, and the way in which we teach really defines who we are as people and as mentors. My goal today is A, to keep you awake and not to bore you, and B, to really talk about the endless pursuit of mastery in everything we do, which I think what makes winners winners, that they know they can get better. They see criticism as the greatest gift in the world, and they're not thin-skinned about it, and they desire to get better. The destination is not achievable, but the pursuit of mastery The endless pursuit of mastery must be a pursuit that offers endless significance to others. If the only reason to achieve the goal is about you or about your excellence or this or that, it will not work. David, hang on one quick second. Hang on. So as I was saying, the pursuit of mastery must be towards something that's much more significant than about you or your own goals. It has to be about helping other people, achieving better goals for patients, and teaching other surgeons. So the impetus must be a mission bigger than you. Now, I personally knew after doing 10,000 open operations that minimally invasive surgery was going to win, and that a computer platform would win and not chopsticks or video assisted operations. That's just the reality. Anybody out there wants to question that, I'm happy to talk about it. Video assisted thoracoscopic surgery is great, but everyone knows that some sort of computerized robotic system is going to win. And so we immediately switched in 2010. I was not a pioneer. I don't like to be called pioneer because Frank Amelfi in Italy was 10 years ahead of me. Bernie Park, my friend in New York City, was ahead of me, as were others. I was honored to come along, and maybe we've done a little bit more and we've written a little bit more, but they're really the pioneers here, not me. The only way to get better in a process is honest introspection about what you do poorly. And no one does more things poorly than me, unfortunately. No one's made more mistakes than me, unfortunately. I like to not repeat those mistakes. And I'd rather have those of you listening today, and I'm honored to be in so many countries and talk to so many surgeons today, to stand on my very short shoulders and see what we can see now and not repeat the errors we did. So honest introspection, weekly review of process and structure, and it requires high fidelity data where you're honestly putting in your outcomes. And your outcomes have to be based on a vision of leadership, and you must look at teaching and look at your videos. So first, I'd like to invite everybody to come. I know with COVID, it's hard to travel to New York City, but in about 5 months, when the vaccine is out and it's distributed, hopefully a couple of months after that, and I do think we're going to start distributing here actually in New York City in the next few months to healthcare workers. We'd like to have you come. That's my email address. Please feel free to email me, and that's my cell phone. I give it out to all my patients, and I give it out to all the surgeons I coach. Here's a picture of our new $1.2 billion Kimball Pavilion. We're honored to have you come. It is the most advanced hospital in the world. That probably won't be true in another year because other hospitals are being built elsewhere, but it is as of right now with the best operating rooms in the world. This is a picture of one of the 40 operating rooms we have at Kimmel, and I'm honored to be a small part of the team there. We hope to have you come. So I think the deliverables today are metrics, accountability, ownership, and leadership. If you can focus on doing those 4 things, not just in your operating room, but with your families, with your children, with your medical students who are your children, you're going to get great outcomes. Now, when I got to NYU Langone, for 19 years, they had been doing lung cancer surgery, and they were only a 2-star program. Within 14 months, we made it a 3-star program doing the things I just mentioned. There are only 6 hospitals in North America that achieve a 3-star program for cancer surgery. Lung cancer surgery, we're thrilled to be one of them, but this is the end result of the journey, the end result of the things that I mentioned. And I'm going to start off the first slide with the end result. So this looks at my experience in over 1,168 robotic consecutive anatomic pulmonary resections. These are consecutive and not selective. Over that time, I did 2,058 robotic procedures. So let's just talk about the lobes and the segments. There were 828 patients taken to the operating room to have a robotic lobectomy and 349 to have a robotic segmentectomy. Of the 349 segments, 347 is depicted here, were completed robotically, meaning only 2 patients were converted to thoracotomy. Now, note that experience was November 2013 to now. So I had 2 years of experience under my belt before I started doing robotic segments. I did my learning and my teeth cutting on lobectomy. We did convert to 7 patients to lobectomy because of either margins weren't good enough, et cetera. In addition to 2 people who were converted for thoracotomy, none of them were for bleeding, but rather inability to conclusively palpate the nodule. We've had no conversions in the last 221. Median operative time is 86 minutes. There's been no operative mortality in our last 350 anatomic pulmonary resections, and no 30 or 90-day mortalities in any of these 349 patients. Now, if you look at the overall mortality in this entire series, there were 2 patients out of 1,168 who died within 30 days, none really related to the procedure. That's a mortality not of 1% and not of 0.2%, but of 0.17%. That's obviously the lowest anywhere reported in the literature. We haven't yet reported it. This paper is currently at the JTCVS. The 90-day mortality, which is usually doubled, is actually not doubled. It's only 1 patient higher, 3 patients for an operative mortality at 90 days at 0.25%. Now let's just focus on the lobes. There were 828 consecutive patients taken to the operating room to have a robotic lobectomy, of which 794 were completed, meaning 34 patients, 6 plus 28, 34 patients had conversions. And we're going to go over those conversions. There's only been 1 in the last 300. Median operative time is 1 hour and 37 minutes. All patients had 5N2 stations. Every patient had at least 1 lymph node from 5N2 and at least 2 N1s. And all of them had an R0 resection. Only 1 patient had a blood transfusion in the last 500, and that patient had 2 previous thoracotomies, 2 of them, with ribs removed. He was on dialysis and started off with a hemoglobin of 7 and had a calcified pleural space, both viscerally and pleurally. And we finally opened because we were oozing from the pleural dissection. The 1 conversion to thoracotomy was a patient who had 6,600 gray of preoperative neoadjuvant chemoradiotherapy and also immunotherapy because of a high PD-L1. And we reopened only after we completed the entire operation robotically, did a beautiful robotic right upper lobe sleeve. But when we did the anastomosis, there was tension there. We made a small incision just to buttress it with some pericardial strips. So this is the final destination. This is what we think good looks like. And the question is, how do you get here? And the truth is, it has nothing to do with me. I wish it did, but it doesn't. And that's not humility, because we all know surgeons aren't humble. That's reality. It has to do with the people around you. It has to do with your ability to engage the weakest link and get them to care and love what they do as much as you do. So I thought I would quickly show you my path, which is not very good, but we're going to air the dirty laundry now. So if you look at my first 168 robotic pulmonary resections, it took a year to do that, 14 months. 13 of the first 168 required conversion. That's not very good. That's pretty embarrassing, actually. And if you look at it, 148 were completed robotically, but 13 were converted, 106 lobes and 16 segments. There was no mortality, and they all had good cancer metrics, R0 resections, all visible lymph nodes removed, et cetera. Hospital length of stay, 3 days, but the median operative time is not very good. It's over 2 hours. And the conversions were 12 in the first 62 patients, 12. And then 1 in the last 161, including the next series. And we found that there were things that made us better. So what we did is every day, we reviewed the video every night, and it takes a long time. What did we do well, and what could we do better? We started using the 4th arm for better retraction. We used the vessel loop to guide the stapler, because back then, I didn't have the beautiful XI, I had the SI, and we were using a handheld stapler. We removed the tumor above the diaphragm, because before people were putting a hole in the diaphragm and taking it out. And we started carbon dioxide insufflation, which everyone said were crazy, but of course now everybody does it that way. What did we learn from this? Well, first of all, we learned humility. My hubris for thinking that I could resect everybody perfectly showed that I was an idiot, as usual, and we couldn't. That only selective patients should have been done. But I decided in 2010 I was going to be a robotic surgeon, so I started doing it. And what were the changes to the mindset? The change to my mindset was that I was only as good as the weakest link in my team. And I don't mean technically, I mean emotionally. What were they thinking about when I was operating? So I put a camera in the operating room and I filmed the people in the operating room while I was deeply immersed in the console. And I learned a lot from how those team members were engaged and who I wanted on my team. Now, flash forward a few years later, here's my results after my first 800 robotic cases. 400 were pulmonary resections. This is out to 2013. Now, 394 of these patients were for a planned lobectomy and or segment. There were 41 conversions now to open. Not all of these were in the lung operations, only some, but the conversions were going up, but the percent was going down. And again, no conversions in the last 100. So we put up on the wall, when was the last conversion? Just like nurses stations do with when was your last urinary tract infection or your last central line infection. I was doing that in the OR. When was our last conversion? Everybody focused on that and we didn't want to convert. What about the 30-day mortality? One patient out of 394, 0.25% at that time, 2 patients at 90 days. What did we learn? We now learned that we could do every single operation robotically. We no longer needed to be selective. What we needed now was more access from the hospital. How did we leverage our profitability, our contribution margin, our highest patient satisfaction? Our service got 8 years in a row, the highest scores from the patients in the hospital. How do we leverage that for the hospital to give us resources? And my vision and plan at that time was that there was no limit to how good you could get. You know, I just talked to my son who just finished some interviews for a job. And I think he performed well because he believes when he looks in the mirror, he's not very good. And I love that. You know, we all look in the mirror and I'm not 6'4", blonde hair and good looking. I'm 5'2" and I am what I am. I see the reality and I know that I got a long way to go to get better. And I think if we had a 360-degree view of ourselves, we could leverage the people around us so much better. It can't be false humility. It has to be true humility, which is easy to have when you're me. But when you're in the operating room, you need to be confident. So it is this intertwixing and this yin-yang that makes it difficult to be both confident and, yes, humble at the same time. So I think I've showed you our results after 2,058 robotic operation, and to show you the final evidence of the lobectomy, and that was, let's be perfect. So starting 2 years ago, I decided that we were going to accept nothing but perfection, meaning the following things were going to happen. The problems we had were finding small nodules, so we wrote a paper on using ICG dye. More about that later. We decided air leaks for keeping people in the hospital. We said we will not have any air leaks on the day of surgery. Every patient will have no air leaks. Every patient's going to get their chest tube out on the day of surgery because we're going to handle their lung better. We're going to have no chylothoraces. If you've seen what I've published, I had a 1 to 2% incidence of chylothorax. That now has been not mitigated, but eliminated. And we're going to remove everybody's chest tube on the day of operation. And we're going to discharge everybody home on post-operative day 1 by 8 a.m. So we did a study to look at this. First, I won't bore you with this paper. Here's a paper we did looking at ICG. We can talk about this later. I went over this in my segment. But everything that we had a problem with, we did a study on and we published it and we got better. Here was our goal for this study. We looked at 253 patients over the last 2 years, 138 lobes, 115 segments. And we said we want every single patient to go home on post-op day 1. Did we achieve it? No. 67% of the segments went home and 40% of the lobes went home. But in the last quarter, meaning in the last 1/4 of the segments and lobes, 97% of the segments went home and 68% of the lobectomies went home. And what are the outcomes? No deaths at 30 or 90 days, a readmission rate of 1% now, and most people went home on a day. So I think, David, for keeping this interactive, I'd like to get some questions, if you can translate, and we'll stop there before we go to the video review of the bleeding. And I hope that wasn't too long. Looks like we're right on target at 8:21. Questions?
Sure. So one question came in is, can you talk about the advantages of the CO2 insufflation?
Yeah, it's a great question. The CO2 insufflation gives you a whole bunch of advantages. It allows more room for you to work in. It increases the domain for the robot to be able to move things around. It more rapidly decompresses the lung, leading to, I think, easier fissure and pulmonary artery dissection. It may even tamponade some small venous bleeding, which will then clot off on its own. Although at the end of the case, we turn it off for 5 seconds and look at our ports. And it pushes the diaphragm down, and it completely eliminates the need for a diaphragmatic retraction, inferior caudal retraction stitch.
Great. Thank you for that. One other question before we move on is, did any of your outcomes change after you started using the Da Vinci stapler?
It did. Our conversions went down. Now, let's be fair. Maybe the conversions went down because I had, 1,000 robotic operations under my belt. Maybe the conversions went down for other reasons. The team's more experienced. I don't know. But I think the ability to have the surgeon to have control of the stapler is a critical element of the operation. Now, every surgeon that's done this wants a smaller stapler. I hope to hell you're going to get us an 8mm stapler. We would love to see 5mm instruments on the XI and a 5 or 8mm stapler. When that happens, there will be a gigantic game changer in patients' pain when we go to 5mm instruments. We saw that with the SI, and those patients had almost little to no pain at 3 days with 5mm instruments.